So welcome everyone. I'm Kathy Scrimshaw. I'm going to be your host and moderator today. Welcome to the Collaborative Mentorship Network Collab Forum. And we're really excited to let you meet the disruptors that are working on the other emergency we've all been dealing with. And we're going to kick it off with a land acknowledgement.
My name is Carolyn Nowry, and we would like to recognize that our work takes place across the territories of Treaties 6, 7, and 8, and the homeland of the Métis Nation of Alberta, including the Métis settlements.
Je reconnais respectueusement que je suis située sur la terre du Traité 6, territoire traditionnel des Premières Nations et du peuple Métis.
At some point, for most of us, our families immigrated here and began new lives in this new land. Many Indigenous peoples were displaced from their traditional lands and ways of life. This began a chain of atrocities, the effects of which persist to this day.
I'm Janetta Salvallagio. I'm an academic family physician in Edmonton. I'm Misquechi Waskahigan. So what does land acknowledgement mean to me? It's about connecting to all beings, because that's what health is all about. It's not just about me individually as a biologic system. It's about all of us together and all of us who live on the land. If the land is sick, everybody and the land suffers. It's about understanding that disconnection through homelessness and mental illness has an impact on everyone, because we are all connected. It means walking with, not for. It means amplifying voices. It's about insisting that I'm at the table to change some of that.
So thank you for that. Now, I do have to go through a few housekeeping items. The slides are just coming up now. First of all, I'm Kathy Scrimshaw, and my one disclosure that I do have is that I am a part-time employee of the Alberta College of Family Physicians. I have no other disclosures. My colleagues with the CMN, Dr. Leah Phillips, Carrie McNabb, Agatha Grachowski, are all full-time employees of the Alberta College and have no other disclosures. This program does receive financial support from the Alberta College of Family Physicians through a Health Canada Substance Use and Addictions Program contribution. It does not receive any other in-kind support. And the housekeeping piece is to capture your attendance. We need you to click on the survey link in the chat log to enter your name and email. We will be using the chat log to collect questions, and you can also use the raise hand feature to verbally ask a question. There's quite a few of you, so be patient, and you may need to put something into the chat saying you want to ask something. We'll have a dedicated time for questions and answers at the end of the session, and an evaluation is really key. When the survey comes up, please try to fill it out. That would be great. The learning objectives are pretty simple. We want everyone to understand the current impact of opioid poisoning in Alberta and reflect and discuss on ways we can advocate and provide harm reduction and compassionate care to our patients that may be using substances. Now, I know some of you may have seen this, but I know that it's been a really tough 2 years for everyone. I just want to thank everyone when they're feeling down and burnt out to give up an hour or two this evening to meet these inspiring women that are doing all this amazing advocacy and harm reduction work, all in different ways, locally, regionally, provincially, and nationally. So thank you. We will be posting this in the chat. These are just some things you might be interested in taking a look at about all our panelists. We have a full feature film that Esther Tailfeathers' daughter is the filmmaker on, that is actually playing in theaters now. Bonnie Larson has an excellent blog post talking about the closure of supervised consumption site in Calgary and advocacy. Ginetta is working with the Edmonton Zone Medical Association Opioid Poisoning Committee and sort of why that's happening. And Boots on the Ground is exactly that. These amazing women are out on the ground in Edmonton doing harm reduction in the alleys and on the streets of downtown Edmonton. So take a look at those. So without further ado, I sort of have introduced our panel. Detailed bios will be posted in the chat, so you can take a look at that, and their disclosures are there. So we do have Esther Tailfeathers, who is a name most people would know. She's an amazing local community leader on Kainai First Nation, as well as a provincial leader and a national leader, both in innovative harm reduction and addictions treatment, but also in Indigenous health. Our next speakers are Alissa Miller and Angela Staines. I hope I said that right, Angie. And they are a dynamic duo that are out on the streets, boots on the ground, doing harm reduction in Edmonton, and they're going to talk about some of their work. Our next speaker will be Janetta Salvagio, who is, as you saw on our video, an academic professor of family medicine at the University of Alberta. And she has a wide experience in working with vulnerable populations and supporting advocacy. And finally is Dr. Bonnie Larson, who is from Calgary, has worked in the inner city and with multiple vulnerable populations, including refugee medicine, Indigenous populations, homeless populations. She has many awards, many interests in research and advocacy. And without further ado, we're going to introduce you to the Disruptors. And our first one is Dr. Esther Tailfeathers. So take it away, Esther.
Thank you. Thank you very much, Kathy. So I work on the Blood Reserve. I've been a family physician here for like 20 years, and it hit the news in about 2014 that our reserve had been hit with the opioid crisis, and they were calling them Oxy 80s or fentanyl. So in the fall of 2014, we started seeing multiple deaths, and between the fall of 2014 and March 2015, our community scrambled to save lives once they learned that this was fentanyl. So the very first thing we did is we had this huge discussion on abstinence versus harm reduction. And it was very difficult to educate the community, but once people recognized that they could save lives with naloxone, especially family members who had lost somebody, the community began to adopt naloxone. We were only the second community in Alberta who started using naloxone as lay people. Edmonton Streetworks was the first, and so we were the second and the only First Nation in Canada to start using naloxone. It was a really good exercise. People learned how to use the naloxone. We distributed the kits. And we had, like I said, we had about 20 deaths between August and March. And for 3 months after the community worked with the naloxone kits, we had 3 months of no deaths. People were saving lives. And so we, that wasn't the end of it. We figured out that we had to keep on going. And so we started opiate agonist therapy, and this was another big discussion. So we started actually prescribing Suboxone, and it was triplicate. It was a lot of discussion with the community and a lot of people who did not believe in it. But the first Christmas after we started prescribing Suboxone, we had parents that had their children at home, and they had groceries in the cupboards, and they had a Christmas tree up, and they actually had a good Christmas. So people began to embrace Suboxone. It's commonly used on the Blood Reserve, and I think that it had spread to many communities after that. We've started methadone prescribing as well. We have a walk-in clinic on Wednesdays for Suboxone and methadone. We've had a number of harm reduction projects that we've started. We started a mobile Suboxone unit to deliver Suboxone to many of our people who do not have transportation. We had a safe consumption site in February 2018 because we had another spike in deaths. But that was not successful in our community because we had not fought the stigma before we brought the unit onto the reserve. So some people parked in the parking lot and watched the individuals that were going in. So as a result, we had very, very few that used the safe consumption site. So what we did is we came up with an idea called a safe withdrawal site, which is the first detox on reserve in Canada, which uses we use, if we have to, light sedation. We use benzodiazepines. We use fluid resuscitation. We have diverted the ambulances from the emergency rooms to come straight to our detox center. And so we keep people there and try to get them comfortable through their first 72 hours. And then we offer them 2 to 3 weeks or more of staying at our detox, and we work on their treatment program. So they go directly to treatment from our detox. There's no gaps in between. So we're finding that this is very successful, and we're seeing lots of people coming in from all over the province. As a result, we're busting at the seams. Next slide. So these are some of our own stats. We decided to start keeping stats, and if you can see on this one, we started taking a look at when we had overdoses in the community, and we were able to look at the patterns, and the patterns followed the flow of money into the community. So when it was social assistance or AISH or other paydays, we saw a spike in our overdoses. So we started keeping data, and we started responding to what was going on our reserve. Next slide, please. So what are the underlying reasons for this crisis? Number one is historic trauma. We know that residential school and the adverse childhood events that occurred in residential school, and the events, the trauma that has become intergenerational, is one of the main reasons our people use, and they use to treat the pain. So many people are self-medicating, and we had problems with alcohol, but it's become polysubstance abuse. And the number one reason we feel is historic trauma. The second thing is social determinants. We know that poverty has a huge impact on the use of polysubstances or any substances. We find that the loss of hope and having to live daily in environment of poverty really is one of the second highest impacts. The third thing is service delivery in primary care and prescription drug overprescribing. And I've got a slide coming up that will show you that. So can we move to the next slide? Okay, so the adverse childhood experience study, most of you may have read about the Kaiser Permanente study. And so I just added a slide in here, and it definitely tells us what's happening within Indigenous communities, and certainly my own community, where it starts with the adverse childhood experiences. We see a disrupted neurodevelopment, which we call behavioral disturbances. When we have children that come in, we're not recognizing that they have trauma. We see social, emotional, and cognitive impairment. We see children who have delayed learning. We see children who we say have learning disabilities. And then we see early teens, 12, 13, 14-year-olds that are adopting high-risk behaviors, which often leads to injury. And injury leads to the use of opioids, Tylenol-3, and chronic use of opioids. So this is kind of cyclic, and we see, what one thing leads to another. As family physicians, we see disease, disability, and social problems at a younger age in Indigenous populations, and then of course early death. So the life expectancy of an average an Indigenous person in Alberta is actually 12 years less than the non-Indigenous person, and it exactly is reflected by the pyramid of the adverse childhood events. So this is the data that's being kept by FNIB, or First Nations Health Branch. And they've been keeping a tally of the opioid dispensations to First Nations, non-First Nations. And so on the left, you see the male non-First Nations, is the least prescribed opioids versus the First Nations male, which is the pink that goes way out into the right-hand side. So we're seeing the patterns of 2 times higher prescription rates for First Nations compared to non-First Nations. And we all have ideas about why that happens. You know, many communities don't have primary care. So if they do, it's either visiting the closest community or a family physician that goes in and is inundated with the number of patients they need to see. So time-wise, resource-wise, and access-wise, we're seeing a result of that. So some stats. First Nations in Alberta compared to non-First Nations, opiate toxicity deaths are 3 times higher. You'll see that in the Alberta opioid reports. Emergency department visits were 6 times higher. Hospitalizations related to opioids were 5 times higher. EMS responses in Edmonton and Calgary were 7 times higher, and the opioid dispensing from community pharmacies is 2 times higher. So you see significant numbers in First Nations in Alberta. Next slide, please. So our children, what is happening to them in this crisis? We're seeing an increase of traumatic experiences, an increase in substance misuse at younger age. We're seeing kids as young as 13 in our detox who have been on the streets and are addicted to multiple opioids. Some are already shooting up heroin. And in the recent year, we've seen a huge increase in methamphetamine use as well. So you'll hear them say they're using down and they follow with speedballs. So, you know, our picture with withdrawal is a really mixed picture. And especially in teens who basically have brains that are still developing. There's an increase in children going into foster care, and there was a report today about the number of deaths of Indigenous children in foster care in Alberta. We've seen increase in neonatal abstinence syndrome. Here on the blood reserve, we watched for the first 3 years of our crisis, and our reserve has an average of 100 babies a year, so it wasn't hard for me to figure out percentages. The first year we had about 14 babies that were born in neonatal abstinence syndrome. The next year we had about 24, and then we had the following year 30. And we think it's getting pretty close to 50% now of our babies born into neonatal abstinence syndrome. We've seen an increase in poverty, and we're seeing children being recruited into the sex trade, and it's really sad to be seeing this happening to our children. So what are we going to do as a collective? We need to address poverty and social determinants of health. We need to recognize that trauma and trauma-informed care is needed as part of our treatment and recovery. We need to address addictions issues in our community and start harm reduction and support it. We need to increase the scale and scope of treatment in Indigenous communities. We need to share positive outcomes and programs, collaborative effort between education, health, and children's services, and we need to recognize the role of primary care in this crisis. And we need to begin new pain management strategies, which are not opioid-based. Next slide.
I think that was your last slide. You did awesome there, Esther. I know that we went a little bit over, but thank you for setting the stage there. Really appreciate that. And so next up is Alissa.
Wow, that was just incredible for setting the stage. Thank you so much, Dr. Tailfeathers. My name's Alissa. I'm here from Boots on Ground Harm Reduction Society. We're an incorporated nonprofit society with a working board of directors. My co-founder Angie is here as well. And we basically run urban street teams to do drug poisoning response and harm reduction interventions, which also includes giving out safer use supplies. The type of street level work that we do is a little unique in the city in the context of we consider it to be high risk. So we do very small teams, usually just 2 or 3 people, It's at night, and we go anywhere that we see an increased risk of a drug poisoning or concentrations of people who use substances that are structurally vulnerable in many different neighborhoods in Edmonton. We do focus specifically on structurally vulnerable people who use substances. And our team is very fortunate to be informed both by our varied lived experiences as well as our professional trainings. My background is more primarily in mental health crisis intervention. I've been a peer crisis intervener since about 2001. More recently, I was able to receive some training in applying DBT skills and ACT values-based work with peers, and I'm the data nerd. So in addition to doing our street teams, we also run in-person scans of areas of known concern 5 to 7 days a week, varying times. We try to run in pattern where we need to go, how we can respond rapidly to shifting supply, shifting areas in the city that are seeing increased need. That's a combination of e-scanning, data modeling that we can access through the Alberta government and also internally through the city. And also the lived experience and listening to the folks we interact with when we're out on the street. That puts us in a really unique position of being able to build trust and share knowledge, not just about, say, for example, how to use naloxone, but also to talk with folks and say, hey, there's this really heavy down out there right now, and it's got a really heavy benzo effect, really go slow. Like, this is what we're hearing, this is what we're seeing, or they'll tell us information and then we can share and pass that on to other folks. So we look at this from a place of dignity, compassion, I like to say radical acceptance and resistance, because we are working against the tide with a lot of neighborhood members. And so part of our disruptive work is also strategic in going inside systems, whether it's governance or policy, and providing really strategic points that are informed by lived experience, but that speak to the people that have the power to change policies at the municipal level, at the provincial level, and so forth. We've had a lot of success in a rapidly scaled up project since we saw street level drug poisonings absolutely skyrocket in the spring and summer of this year. Building trust and that dignity and just that sense of social inclusion, sitting down with someone and they say, hey, this is a new supply. Can you just sit with me for 15 minutes while I shoot this out? Because I just want someone to spot me, right? Having the ability to be there for folks, that's our radical acceptance. That's our building trust and giving people dignity and autonomy, meeting them where they're at. I like to say we're meeting people where they're at, but we don't want to leave them there. That's a challenge systemically with us, with all services right now, because services are siloed and we have massive issues with accessing detox, recovery options that are person-centered and what the person is needing. Coordination, communication barriers. We need to look holistically at different organizations and groups of peoples, as well as people who use drugs, and figure out how we can all coordinate these services together to meet every individual's needs. Sometimes when we're out there, we're just trying to keep people alive, right? Other times we have opportunities to witness histories. Folks tell us why they use, how long they've been using. The stories of trauma are really heavy. And I think we're really honored to bear witness to those and hopefully give someone a bit of peace in knowing that we're not going to cross the street or run away or feel scared to walk by them. Yeah, that dignity is just so important. Can't think of anything else that I would like to say right now other than thank you for the opportunity. And I also found this very fascinating for myself personally, because I am a survivor of 2 car accidents and a physical assault, and I have 2 chronic pain conditions. And so doing that and doing mental health and mental illness interventions, these things are very, very close to my heart personally, as well as professionally now. So thank you for the opportunity to share.
Thank you so much, Alissa. And your partner in Boots on the Ground is next, Angie.
I'm Angie Staines. I'm the other half of Boots on the Ground. So I'm more of the, Alissa does, we both are together out in the alleys and everywhere. Alissa does a lot of the strategic and I have the gift of the gab. So I carry a bag with me with safe for use supplies. So we have pipes, we have clean needles, straight shooters, which are also used for pipes, many different things, tin foil, and we just walk and try and pivot as best as we can with the changing supply. As anybody here, especially Esther, I noticed she mentioned that you really need to pivot. You can see the patterns of, money coming in, even full moons. So it's definitely, it keeps you on your toes. The biggest thing, I come from the experience, I have a son who has been in active substance use for 10 years. I'm also a member of Mom Stop the Harm. It has been a learning experience for me, and it has been a journey coming to this place. I knew nothing about harm reduction. I believed in tough love in the early days. So this has all that craziness has brought me to this place. So for me, it's really about giving these people some humanity. My son once said to me that he was tired of people crossing the street to avoid him. And that broke my heart. So I think I just want everybody to understand that this is someone out there. And we really need to, both Alissa and I really take that seriously. And so we really just try and provide some dignity and just treat them like we would want to be treated. And they always, they're always so kind, and we are very honored to hear the stories and the histories, and it fills my heart. So my biggest goal, I think, in this, besides keeping people alive, which really what is harm reduction, just because somebody's using substances doesn't mean they need to stop or they're ready to stop. And our job really is just to make sure they are alive to see tomorrow and see what that day brings them. So really reducing that stigma, I think, is just so incredibly important. Within the medical system, it really stops people from going. We see people with open leg wounds that will not go to the emerge. We carry some basic supplies. So we can do some basic wound care, but the stigma these people have felt through so many aspects of society, really, and the shame that they carry with them because of their substance use really fuels everything they do in a day. And if we could change that, we could change a lot. So I guess we are reversing overdoses. That is a lot of what we see a lot. It feels like we're barely holding it together. We have a relationship with EMS and fire. They know who we are, and we're all grateful for each other. We're seeing a lot of benzodiazepines. It's what else is in. Heroin hasn't been out here in a long time. People know they are using fentanyl. It is not a surprise. We don't have heroin here. I don't think we've had it for a few years, few and far between if it is. So it's what they're filling the fentanyl with as well, and the carfentanil. There is people, my son actively uses carfentanil on a daily basis. But like Esther said, it's the methamphetamines as well, the benzodiazepines, which is making the reversals very tough. And really scary additives like metformin. So you're seeing a lot of really low blood sugars. So maybe we can bring them out of the opiate reversal, but if you have a blood sugar of 1.9, you're not doing much. Warfarin, so we're seeing a lot of bleeding. Just really, really scary things. Yeah, I really, Esther, when you said the loss of hope, I think that's really what it feels like out there right now. It's a very dark, there's some very, very heavy drugs. It's very dark out there. It's also winter, so it's very dark, but there's a really heavy feeling. I know at the Speedy, where I also work part-time, you just feel it even at the safe consumption site. It's just a really heavy feeling, and it's affecting people's minds, these drugs. And so I mean, to me, the only solution really is decriminalization and making sure we're reducing that stigma and just understanding it's people's human right to use drugs. So that's really all I have to say. I'm so grateful to be here tonight and among all of you. And everybody here is the reason why I do this, and I'm very honored. So yeah, that's really it. Thank you so much.
Thank you so much, Angie. And with no further comment, we'll go on to Janetta. I know we're running a little bit over time, so I may cut you off, Janetta, but it's been just so great to hear from everyone.
Thanks for doing this tonight to the ACFP. I just want to make a comment, first of all these fantastic women, it's very humbling. But I will say that we probably share one thing in common. I hope I'm not speaking incorrectly, but it occurs to me that we all grieve, but we all very much love. And we're coming from this from just to hurt is to love, and to love is to hurt, and processing things is really important. And I think one of the things that helps us to process things is to keep loving and to keep sharing that. And we're doing it in different ways. And I think we all share our gifts in our own ways, and we have our strengths. And so we're telling our stories. We're doing what we can because we know that we can share that, and we have the power to share that. My pre-state, before the drug poisoning escalations of the last few years, I've been a community-centered researcher and practitioner for a long time, and really whet my community engagement chops at Streetworks harm reduction program, where I used to do outreach. And I am fond of telling anyone who wants to listen that the people like Rosemary Fyant and Sandra Johnson and some of the outreach workers who used to work at Streetworks with me taught me more on van ride-along shifts than I ever learned in medical school about how to really care for people and what really matters with respect to relationships. And it comes down to right relations. And so I take those lessons to heart and have continued those lessons through research, and have continued to work with Alberta addicts who educate and advocate responsibly in some community engaged research, trying to do work that is meaningful to them and that is impactful to them, because otherwise I don't see that the research has any ethics whatsoever. And so that journey kind of landed smack dab in the middle of massive widespread grief that all of us are feeling now over. All of a sudden I'm losing patients left, right, and center to drug poisonings. I'm losing colleagues and friends. So people who have done meaningful scholarship with me are gone. It is incredibly saddening. It is incredibly angering to me. It's cumulative. And what is particularly difficult with this grief is that it's all preventable stuff, all of it. It's structural violence. It's very violent grief, and that is very difficult to bear. I want these to be deaths with dignity. I want people to have life and death in dignity, and that's not there right now. At the same time, I come from a space of fear of scrutiny, fear of being gaslit, fear of being muzzled. There's been a lot of that lately that has been very, very difficult to contend with. And I think all of us have had that experience at one time or another, trying to advocate, for example, with COVID and this time of crisis. But I mean, it is tremendously demoralizing to be told you don't belong, that your thoughts don't belong, that that's not the prevailing view. I had to get past that fear. I realized that there were so many people who were being hit even harder with grief, who were being, who were hurting so bad, or who weren't able to speak, and that I had power and privilege in my role as a physician and as an academic, and I realized that it was my turn to speak. And so one thing has led to another. We have put together in the Edmonton Zone Medical Staff Association, bless them, we have a opioid poisoning committee. So it is one vehicle through which we can advocate, and we can advocate as a collective. So we don't feel alone in our grief and in our hurt. All of us in that committee have stories. All of us are connected to this. All of us are physicians connected to this. So we want to share our power and privilege and speak out. It's time. It was more in time. It's overdue. Our role is to create right relationships, to listen, to create awareness with the public and with government. We want people to listen. We want people to understand what the impacts of scary policy decisions are going to be. We want to listen back. We're in the process of consulting. We do not believe that the only valid knowledge can be found in scientific publications. We feel that knowledge can be found in stories and can be found in situated experience, and we are doing our jobs with that right now. And we're going to take all of this shared wisdom and honor it with recommendations that we feel will have impact. So that's our work right now. How do we do it? We message with love. We avoid personal attacks. We really want to focus on the issues at hand and what will help people get through this and live with dignity. We want to center the margins. We want people to get rid of the prevailing assumption that this is strictly an addiction crisis, but that it is a poisoning crisis and that it is entirely preventable. So that's where I'm at. I will keep my thoughts to that because I'm aware of time, and I'll hand it over to the next speaker.
So thank you so much, Ginetta. And finally, we have Bonnie Larson. The last words are yours.
Hi, everybody. Thank you so much for coming out tonight. It's probably the end, getting towards the end of a very long week. I don't know if it's that blood moon or what's going on, but something definitely is messing with time and intensity. I am going to try to be fairly quick here too. There is a lot I can say. I started prescribing buprenorphine naloxone in 2016. So other than the addictions docs, I think I was one of the first family physicians to start prescribing Bucknell, or Suboxone as the brand name is, and have seen this drug poisoning crisis since the beginning. Feels like since the beginning of time. I am so very honored to be with this group. For a long time, as you know, commenting, I was one of the first in family medicine to be doing this work. Felt very alone, especially not just in the medical part and the, at the patient level, but also very much at the advocacy level, because I couldn't find many people that sort of were feeling the same way that I was about the injustice that I was seeing in front of me. And I'm just reflecting on that right now and letting my voice be a little emotional, because I think that we are growing, and that these amazing women are definitely kindred spirits, but not just that, extremely dedicated, courageous, strong, amazing shit disturbers. And I am super proud. I can't even tell you how amazing it is to listen to everybody. I'm not going to say much more about me, but what I would like to say, given what the comments have been thus far, is I want to ask the question of, like, why are we disruptors? Like, why are we having to disrupt at all? Okay, so I want you to imagine this. So I'm a cardiologist. Just pretend for a minute. So far from a cardiologist, but pretend for a minute that I'm a cardiologist. And we're having this conversation about disruptors. And I'm here and I'm saying, I'm trying to get you to understand how important it is to put cardiac cath labs in every community in our province. And because coronary artery disease is like the most important thing, and we have good evidence that awesome access to angioplasty for the good interventions, lots of science behind it. I'm trying to convince everybody, but nobody's listening. And actually, in fact, all that anybody wants to do, the policymakers are saying, no, we're not doing that. We're not putting a Band-Aid on the solution. We want to build more gyms, or we're just going to encourage people eating more fruits and vegetables. Or, they've decided that it's not actually that maybe the soul doesn't reside in the heart at all. And so it's not important. And therefore we need to we're only going to fund things that are like for the brain, for, fund neurology, but forget this whole thing. This is ridiculous. We're not going to do cardiac cath labs anymore. It's like that. When I really think about it, I don't understand how not only, the deep running stigma that is, I think Ginetta is alluding to this. We all are. We've all been, why are we fearful of speaking out about things that are for our patients and loved ones and communities, and this affects everybody? Why are we afraid to talk about that? It's because we have been marginalized, pushed to the outside in many different ways. And I think that's part of what sort of prompted the blog in CMAJ blogs, because I was frustrated with selective advocacy and saying, like, wait a minute, like, why is this such a difficult thing for even physicians, even the best educated amongst us, and sometimes especially us, to wrap our heads around? So I'm really happy for this conversation. I want to talk about lots of stuff, and I'm hoping people have questions about things like drug testing and safe supply, and what are compassion clubs, and what have you heard in the news that people like Angie and Alissa are right there. They can tell you all about, like, this. I was shocked when I just learned that metformin is a contaminant in the drug supply. I did not know that. So the folks that are really close to what's actually happening are here. We need information, and we're being prevented from not only caring for our patients in the way that we want to, like as in accompanying them, but we are also being pushed to the margins, and therefore having to shout, and sometimes feels like screaming underwater. A lot of the times it does. I don't know what the next slide, I think the next slide is something related. And then I wanted to talk a little bit about if folks want to get involved, but I think we can maybe either fly through those slides or put them on when we talk about that question. Whatever people want to do. I think the point that Ginetta made about, like, the definition of the drug poisoning crisis. One of the things that I think is really happening in our province right now, and this is a very good example of that, is that policymakers are in my opinion, misdefining the problem, and they're lumping the death crisis in with our overall baseline mental health, and addictions. issues. And so saying, well, it's like this hopping over cath labs and saying, no, we just all do preventative care. Like, let's just hop over keeping people alive and like get them to treatment. But not only is that not logical, because dead people don't recover, it's also not evidence informed at all. We know that there's awesome evidence for things like supervised consumption services and harm reduction services. And we know that there is not any awesome evidence, and there's some crappy evidence, but there isn't that kind of like really low number needed to treat, if you want, for things like residential treatment programs. And so we are putting all of our resources into this and trying to eliminate harm reduction to the extent that, for example, they speak out of one side of their mouths, and then the other side they're saying, take the words harm reduction out of our Alberta Health Services harm reduction policy. And so, what are we actually talking about? We're having different conversations. Policymakers are focusing on calling their response to this death crisis. They claim that this is their response to it, but they're responding to the wrong problem. They are not actually, we are not getting any kind of coordinated response to the mortality that we're seeing, except that we're seeing coordinated reduction of harm reduction services. So I think I'll stop there. Those that know me know that I can get going, and I don't want to, because I really think that we should hear more from everybody else, and also to know like what the questions are and have a conversation. Yes, and this would be the answer to my question about if you want to get involved.
Yep.
Learn about language and get an naloxone kit, clip it, and carry it somewhere where you can see it. Because not only is life-saving, like, carrying a first aid kit or an AED in the mall or whatever, but it is also an act of anti-stigma, where it normalizes that everybody needs to be carrying and advertising that they are carrying the antidote to opioid overdoses. So I'm going to stop there. Okay.
Great. Well, Bonnie, you answered my first question. If you could do one thing to get people to change, you can't say a regime change in government. What could we do on the ground tomorrow that would make a difference? And Bonnie had some great advice there, I thought. Get a naloxone kit. It's just part of your first aid kit. And I agree totally. And I think at least my patients that see Esther on Kainai, almost every house has a naloxone kit. And certainly in Pikani, that's what we're doing. But why aren't we doing that? We have excellent lessons from First Nation communities that are doing this work from Northern Ontario and in Alberta, but we don't spread it. But anyway, so I'm going to start with Esther. What's the one thing you would do? Lightning round while we get some questions.
Yeah, I think the most helpful thing is to have these educational discussions. And to add to that, what we've had to do is we've had to prove concept. So we've been told, no, that's not going to work, but we went ahead and did it, and people are seeing this is what works.
And I think that's exactly the idea of creative disruption, is that, you make the space because the system isn't working. So excellent. Angie, what one thing?
Absolutely anything to reduce stigma, anything at all. Language, anything. If I could just snap my fingers and have stigma gone, I think that would make such a huge difference in everything. Yeah, everybody's outlook, just everything across the board.
Great. Janetta.
Oh, mine is big and hairy and audacious. And the war on people who use drugs.
Okay.
That's one thing. And decriminalize people's bodies, decolonize people's bodies, give them a safe supply.
Alissa.
All of those things, but also the mobilization of community as a whole. Because if we don't have everybody that occupies space in a community on board in the same direction, we're still going upstream.
And so Bonnie gave some great advice on advocacy. Now, Bonnie, I know that you know, that Alberta Views article that says sometimes you got to break the law to save lives, with the experience in Lethbridge. Can you talk a little bit about, you know, getting brave? And I always remember one of our land acknowledgements, actually, I think it was someone from Ginetta's work, who said, sometimes you got to speak out even when your voice is shaking. And yeah, I think we've all been there.
That was Chanel Twan, for those of you who know her. Yeah.
Okay. So I'll throw that question off to Bonnie. How do we do that? How do we mobilize the willing?
Yeah, I think Janetta told the story. Like, we are full of self-doubt. Everybody is. And when you realize what your position in the world is, and actually get honest with ourselves about how much power and privilege somebody like me actually wields, I can't sleep at night unless I'm advocating for, you know, the patient, the community, institutional, and systemic levels, all of them. Like, I can't sleep at night unless I'm doing all of that and trying to address the injustices that I'm confronted with that are brought to me by my patients. So it's very clear to me as a physician that advocacy is part of my job, but it is also good therapy. And so sometimes, yes, I am an introvert and I have a raging vulnerability hangover after doing media of any kind, and putting I find writing is very therapeutic, but it also is like a good medium for me because I am an introvert and I write late at night and I get it all out on paper and then I draft it and then I, you know, put it out and I like hope that it starts a conversation. So it gives me that personal satisfaction, and it's also an art form because the way that I write is actually very much creative nonfiction, and I choose to, you know, I don't know how therapeutic it is to do academic writing. I don't think it's therapeutic, but like this getting it all out is really actually my way of dealing with that moral injury, moral distress, and it also brings together a community. I think it was Shay that said something about like, I wrote an op-ed that was published in the Edmonton Journal a few weeks ago after Esther led a few of us to go and check out what was happening in Wetaskiwin. And I was like, oh, Shay, I don't actually know if anybody reads op-eds anymore anyways. She said it doesn't matter because it's a show of solidarity. And that is enough for me. Like, my heart is a little lighter with that. So that would be my thoughts on that.
Now, we do have a question which you can apply the idea of how do you start advocating, how do you mobilize, and it comes from you and Thompson, is how do we expand supervised consumption services when the province won't endorse them? And so I know Bonnie's got an answer for there, but I'm going to throw it at Alissa and Angie from their perspective on the ground where I'm not.
Well, that's a fun one. Well, legally we can't at the moment. Ish.
I think
Now, I think right now, like, that's why we're pushing really hard on the education and the visibility of our work and the viability of supporting folks who use substances in a safe way. What do you think, Angie?
Honestly, if I think we should get a tent and set it up tomorrow. I think the need is there. You see the need, and there's a point where you just gotta shit or get off the pot, I guess, and you know, deal with the consequences later. People are dying.
Yeah, and I think it goes back to just prove it. We can prove that it works. We can do it. It has been proven. Why aren't we doing more of it? Well, let's just show them that it works.
Yeah, no, I think the time of talking is kind of over. I think, you know, we talk and they die. So I think it's time to just get it done and figure out really quickly.
I'll just say really, really quickly, briefly, I was involved in, as a consultant for the Lethbridge Overdose Prevention Society, who did the Orange Tent in Lethbridge. And the the problem, so the first night when they hadn't let law enforcement know that they were going to do that, which is a choice. Sometimes you could, or you could choose to hope that they're going to support you, but they chose not to. And the first night, somebody actually used the tent and everything went well. And the next night, when Lethbridge Police Service knew that they were there, they showed up that night and every night thereafter and just shone their bright lights right on the tent, and nobody could use it because the cops are there shining their lights on the tent. And not only that, bylaw ticketed the crap out of the volunteers that were running the service. So, and they're still fighting that in court. And so it's not a no risk, no cost prospect, but we do know, and Angie and Alissa know all too well, and Esther does too, that the risk of not doing something is a matter of life and death.
If I can weigh in here, because I saw there was another question in the chat related to like, how do you actually counter prevailing government narratives and other narratives that are out there right now? And that's part of it with how do you get the SCS going? So if I can just tie those two together, because I'm mindful of the time, and yes, I am wearing my heart on my sleeve today. But we have to push the narrative and give that counter narrative of evidence and of love, of both of them together, and step up and open our voices if we have them. And it is my view and the view of the people in my committee and in my research team that we have to change the hearts and the minds of the electorate, and ultimately the government is accountable to the electorate. And so if we encourage people in this province, on these territories, to speak out and to think differently about things and to question the status quo and to push their elected officials and to deliberately disrupt and center the margins, then we're going to get somewhere. So that's where we're focused, is just to change that narrative.
Yeah, I was going to ask that question, and Esther, I don't know if you've seen it in the chat, but basically having what appears to be government policy that's hostile towards harm reduction, how do we change that narrative, and how do we work around it? And I guess that's what I was sort of thinking with the disruptors, is that it's all workarounds, right? We wouldn't be having these conversations, much like Bonnie said, if it was cardiology and angioplasty suites, or, the Alberta Surgical Initiative to get wait times down for arthroplasty. But it's stigma, it's policy, it's worldview. So do you have any words of wisdom on how we change that narrative? And how have you done that in community? I know there's been back and forth.
Oh, we spent hours and hours educating community members and having those discussions. Food makes a difference. People come to meetings and they sit and they listen and they talk. And we've had to talk about respecting other people's ideas. So, the oral violence or the lateral violence around the table, we have to quiet it down and say everybody's opinion and ideas around this table are important. So even those abstinence-based people, we were allowed to, we gave them the space that they needed. So respectful discussion was really important in our community, but more so, for a physician, we're trained to do triage, ABC. So if you have, let's say you have a multiple car collision and people all come into the ER, you do your ABC. So you triage them, who's the most serious and who's the least serious. And so you go and you work on the most serious one. And so in our community, our mortality was directly linked. Most of our people were dying from opioid poisoning. So we knew that, in a physician's mind, you have to address the highest mortality. and morbidity. And in our community, that's what was going on. It's not happening, or it's not as visible in the non-Indigenous community. Well, it should be, but it was so visible in our community. And so, you know, the physician training where you do ABCs, you know, okay, so we concentrate on what we're losing. And, you know, the juxtaposition to what society is saying and current political views are, you know, that's not what's happening. That's, you know, it's not what you're seeing. So it does feel like you're being gaslighted, because we see it, we know it, we say it, we feel the grief, and yet somebody's telling us, no, that's not a priority. That's not what's happening. And it's a really hard thing to, I mean, it's like disassociation in your mind, because you know something is happening in one place, but you're being told that's not the truth. So for all of us who work the front lines, that's a really hard thing to deal with. Is we know the truth, we see the truth, we work with it, and we know the mortality rates and the morbidity, but we're being told in the in media and in the social circles that this is not important. So I think that's what's really hard on us, is that there's that element of moral injury and dissociation with what is real. And, you know, trying not to be gaslit every time, you know, we do something. And, you know, the activity that Bonnie and I were involved in, we got gaslit. And it's really difficult when you put your whole, like, you know, you put all your energy into knowing that this population needs help, and everybody has turned their backs on them.
Thanks for that response. And I know we're a little bit over time. That being said, you did say, every one of you talked a little bit about grief. And my final question to you is, how do you keep going with moral injury and that feeling? What keeps it alive for you?
I give myself permission to hurt and to love, and that's freeing, is to know that's allowed when you're a caring person, and not to stuff that, because it's very powerful. It's very powerful to grieve and to hurt, and then, I mean, to find my people and to organize. There's some really good research papers right around how collectively organizing and collectively advocating can be extremely therapeutic. Bonnie referred to that as well.
Anyone else?
I think watching my son try and navigate the system and deal with everything that goes along with it has really fueled me. So I really try, but I find it fuels my anger. So I'm really trying to switch that into putting love and caring out there. And that's my therapy, is trying to really just heal that pain of not being able to help somebody, by just putting out as much love and respect that I would want somebody to give my child or anybody's child. So that's my therapy.
Yeah, and for me, it's a balance between the ability to be empathic and show compassion to people when they're at their darkest points as well, and balancing that with the known, with my lived experience, my lived histories. That's a lot of emotional weight too. But I also remember that this is my community. My neighborhood is one of the neighborhoods that's impacted by these processes that are hurting our community members that are already incredibly structurally vulnerable. So if I don't lift up the people that need a hand in my community, then my whole community is going to continue to fail itself. So that's what keeps me going.
Bonnie or Esther?
What my patients, I think my my joy and my reward comes from sitting with them, and I feel so humbled by some people who have struggled with immense difficulties and challenges, and they're able to make me laugh, which is the strengths that they have. So I get my joy and my comfort from being with patients.
Yeah, I would echo that for sure. It's the patient, it's sitting with the patients. And one of the things that I've noticed is that you sit with a patient and listen to their story, and they actually reflect back to you parts of yourself that you may have forgotten about or didn't really pay attention to. And in that sense, I find that patient encounters are healing for me. Sort of make whole in the truest sense of the origin of the word. To heal is to make whole, and sitting with patients, I know it's supposed to heal them, but it also fills me up and heals me.
Well, that's a great note. I did get them to put up a slide on being a brave-hearted rebel in healthcare. And I think we found a rebel wild pack that is doing stuff on the ground, and lots of things. This came from IHI, the Institute of Health. What is it? Information? Anyways, that does innovation in the US, but I thought it was pretty relevant for this group. I want to thank you for sharing and starting this conversation, and I anticipate we will be continuing it. There's lots of advocacy we need to do. There's a discussion around supervised consumption. There's a discussion around safe supply, all that we just touched on. There's how do we make the drug supply safe? How do we get drug alerts out there? So stay tuned. We'll be looking to discuss this more deeply soon. Secondly, something, just a teaser, Esther's daughter's film will be trying to have an ACFP showing, and we certainly will open that to all CMN, and really looking forward to that. Please take a look at some of the links we've provided, and stay in touch, and have a lovely evening. Again, thank you so much for spending some time with us. Thank our panelists so much for spending time and sharing, and the hour went quick. So I really appreciate you all staying on till the end. Thank you.
Good night, everyone. Take care. Take as much time as you can when you get it. If you would like to share this recording, revisit it, anything like that, we will be posting it on the CMN discussion board and resource library. If you're joining us and you're not a member of the CMN, you can always join on our website. It's always free, and you get access to all of these session recordings. Just a note that we're going to break in December. There will not be a collaboration forum, but we're going to come back in January, and we actually have Dr. Arlene Cox, a clinical psychologist, and she's bringing us not another New Year's resolution, patient motivation and goal setting in primary care. So thank you to everyone, and good night.